Respected Chairman, Mr. Badr al-Nazar al-Badr, Dr. T.P. Muhammad, the visionary CEO, TP Group of Institutions, Honorable Principal, Mr. Ahmad Hussain Al-Rayani, the dynamic academic principal, Mama Master, the energetic vice principal, Mr. Abdul Qadir, the young and active HMs, Mr. Pradeep and Vasudha Ma'am, coordinators, invitees, enthusiastic students and staff of Almuna, esteemed parents, and my dear friends. At the outset, I would like to thank Almuna for having me, and I am extremely happy and delighted to be here, being part of this special program, Virtual to Real. After having attended 3 excellent sessions of motivational classes, I think it is time for you to listen to some facts, figures, some rules and information. I would like to share my slides to continue my presentation. How to safely accomplish in-person schooling in the time of COVID-19. A safer way of doing it may look something like what is shown in this picture, but we know this is not the proper way that we want. This is not the correct way of doing it. Probably this picture will demonstrate better the practical way of doing it at this point of time. At this time, only the older students, that is, those who are fully vaccinated, only are allowed to come to school. But we want all the students, right from the KG to the class 12, the school to start or resume all the curricular and extracurricular activities in full swing, like how it was before the emergence of this pandemic. Now we are happy that the Saudi government has given approval for vaccinating the children between 5 years and 12 years. And inshallah, we will be able to see the normal schooling at the earliest. And let us pray Almighty to make it happen at the earliest. I would like to divide my talk into these following 7 headings, starting with a brief introduction to this current scenario, some basic information about COVID-19, and how children are affected by COVID-19, how schools are contributing to the transmission of this deadly pandemic, and what are the preventive measures that we can adopt to control this disease, some additional consideration, and finally, summary. The outbreak of this virus has influenced almost every aspect of human life. The school education is not spared. Rather, it is one of the hardest hit areas. Nearly 1 billion learners in more than 119 countries were affected. Maybe the shift to the online classes to some extent has helped in connecting teachers and students, but we know that is not what the school is all about. As we analyze the impact of the COVID-19, the lockdown, and the online classes, we learned that there are a lot of positive impacts as well as a lot of negative impacts. There is a much greater appreciation for the importance of public schools. As children struggle to learn from home, parents' gratitude for teachers, their skills, and their invaluable role in students' well-being has risen. There are more opportunities to advance the integration of technology in teaching. And sharing the learning materials is much more easier. More high-quality learning materials can be easily shared with no or less cost when compared to the in-person learning. And there is increased networking opportunities. Collaboration can also happen among faculty, teachers, across the class, across the schools, across the state, across the nations, or even between the nations to benefit from each other. Now, anyone can sit at home and listen to the lectures of the best in the field. It has decreased the tuition and boarding costs and allowed some scheduling flexibility. And there are a lot of negative impacts as well. Very sadly, a large proportion of the students' populations were untouched due to the digital divide. Here in Saudi Arabia, in Almana, we did not have this issue. We did not have the problem with access to the internet. Everybody could afford the electronic devices and other tools that was required for this online learning. But that was not the case in other parts of the world. Many students, in fact, they lost the complete year of academics due to this pandemic. Many poor countries, they have midday meal program in the school. And the children, for them, that is the main meal of the day. They even lost that for more than a year. We are now beginning to realize that online learning is creating a new set of passive learners that could be a burden in future. Then unprepared teachers for online education. Not all the teachers have the computer literacy or the technological literacy. So those who did not have really found it hard to cope up with the changes, and many even lost their jobs. And more importantly, missing the classroom social environment was one of the highest negative impact of the COVID-19. Schools do much more than teaching children how to read, write, and count. School is a place where students and teachers of different families with different customs and culture meet and interact. Being in such an environment enables the student to learn basics of life, like negotiation skills, employability, organization skills, conflict management, stress management, project management, etc., which are necessary for children for future. Classroom, laboratories, and lecture halls create tightly focused, distraction-free learning environments, which all the tools and space you need so that you can dedicate yourself to the lessons. In the online classes, this may not be that much easier. Schools are an important part of infrastructure of communities as they provide safe and supportive learning environment for students, employ teachers and other staff, and enable parents and guardians and caregivers to work. There are some school experiences you won't gain in any other place. Field trips, school activities, and different clubs, part of which you can be, are just some of these experiences. From each of these activities, you will take life lessons that will be beneficial in your future. Now, coming to COVID-19, or we simply call corona. Corona is actually a group of viruses. There are hundreds of coronaviruses, majority circulating among animals. Only a very few cause diseases in human beings. In fact, only 7. Out of these 7, only 3 cause major or serious illnesses. They are SARS-CoV-1, which caused a severe acute respiratory syndrome outbreak in 2003. And the second one, MERS coronavirus, which caused Middle East respiratory syndrome outbreak in 2012. And now SARS coronavirus 2, which caused COVID-19. We don't know exactly what is the origin of this infection, this virus, where this virus actually came from. Based on the available evidences, we presume that bat was the primary host, and that transmitted the virus to some intermediate host, something like pangolin, which is still debatable. And when some favorable circumstances came together, it got spilled over to man. Initially, when this virus was first isolated, that was named novel coronavirus. But as this virus had maximum similarity to the virus that caused that pandemic in 2003, SARS pandemic, that is severe acute respiratory syndrome, this virus was renamed as SARS coronavirus 2. Now it is SARS coronavirus 2 that causes COVID-19. How does it spread? Actually, it is a respiratory disease mainly. It can involve gastrointestinal system, it can involve cardiovascular system or any other system in the body, but it mainly spread through respiratory route. As an infected person cough, breathe or sneezes, the droplet that contains virus particles come out in the air and fall on the nearby surface. As the normal person who has no infection come in and breathe in this air or touch this contaminated surface and in turn touch his eyes, nose or throat, this virus get entry to this person. And what happens after this virus gets entry? Not all the infections, all the viruses getting entry cause disease. Our body defense mechanism straight away reject most of the infections. This virus needs some receptors to attach to our cells and get inside the cells and cause disease. In case of corona, it is this spike protein. And there is a receptor to which it can very correctly attach. That is called ACE2 receptor, angiotensin converting enzyme 2 receptors. It can attach to this receptor and work like key lock system and enter the cells. And once it enters the cells, it causes inflammation, and this can sometimes overwhelm our immune system. And under certain conditions, there is an increased risk of experiencing severe symptoms of COVID-19 or even death. And after you get infected, you produce symptoms related to the systems that got involved. The common symptoms include fever, fatigue, cough, loss of smell and taste, shortness of breath, nausea, vomiting, diarrhea, shortness of sore throat, muscle ache, headache, etc. But in some cases, it could get severe. People can have very severe fever, confusion, bluish face or lips, persistent chest pain or tightness, severe shortness of breath, coughing up blood, inability to wake or stay awake, very fast heartbeat, etc. These all could be symptoms of severe infection. Those who have severe infection should immediately take medical attention. And what is the prognosis after you being infected? Most of the cases, about 80% of the cases who got COVID-19 infection recover or feel better within 2 weeks. Severe cases, about less than 20% of the cases may last more than 6 weeks or may have permanent organ damages. Some of the patients, after being infected for months after the infection, even after the viruses are completely cured from the body, can still have persistent symptoms. They are called long haulers, or this condition is called long COVID syndrome. About 1 to 2% of the people succumb to this disease. As of today, about 25 crore people have been infected by COVID-19, and about 5 million, that is 0.5 crore people have died because of this disease. In Saudi Arabia, more than 5 lakh people are infected and more than 8,000 people have died. And we know vaccination is the most effective way of controlling this disease, and all the government are very actively trying to implement this vaccination programs. And United Arab Emirates is leading the list. They have vaccinated about 98% of the people, 88% of the population is being fully vaccinated. They have taken 2 vaccines, followed by United Kingdom. In Saudi Arabia, about 69% of the people have been vaccinated, and 62% of these people got both the vaccines. In India, it is about 54%, and 25% have got both the vaccines. How children are affected by COVID-19? Several studies conducted early during the COVID-19 pandemic suggested that the incidence rate among children and adolescents was lower than among adults. However, the lower incidence rates may have been due to, in part, to children when compared to adults having fewer opportunities for exposure due to school, daycare, and activity closures, and a lower probability of being tested. Studies that have systematically tested children and adolescents, irrespective of the symptoms, for acute coronavirus infection or prior infection, have found their rate of infection can be comparable and, in some cases, higher than in adults. Early during the COVID-19 pandemic, children were not commonly identified as index cases in household or other cluster group, largely because schools and extracurricular activities around the world were closed or no longer held in person. However, outbreaks among adolescents attending camps, sports events, and school have demonstrated that adolescents can transmit coronavirus infection to others. Compared with adults, children and adolescents who are infected with coronavirus infection are more commonly asymptomatic. That is, they never develop symptoms or have mild or non-specific symptoms like headache and sore throat. Similar to adults with SARS virus infection, children and adolescents can spread virus to others when they do not have symptoms or have mild or non-specific symptoms, and thus might not know that they are infected or infectious. Children are less likely to develop severe illness or die from COVID-19. Nonetheless, in a study in US, about 271 COVID-19 deaths among persons aged 5 to 17 years and 120 deaths among those aged 0 to 4 years have been reported through July 7, 2021. Underlying medical conditions are more commonly reported among children who are hospitalized than those who are not. COVID-19 vaccination of adults and adolescents could also impact the incidence of COVID-19, as young children will comprise a greater proportion of the population who are unvaccinated and therefore at risk. National COVID-19 case incidence. Now we are coming to schools and COVID transmission. In In a study in US, a national COVID-19 case incidence rate among children and adolescents increased during the late 2020 until about mid-January 2021, then declined, paralleling the trends observed among adults. Neither the increase in case incidence among school-aged children nor school reopening for in-person learning appear to predate the increase in community transmission. There is some evidence to indicate that coronavirus infection might spread more easily within high school settings than in elementary school settings, which suggests that the former may need more move to virtual instruction more quickly when community transmission is high. A study of factors associated with COVID infection among children and adolescents in Mississippi found that school attendance not associated with the positive COVID infection test result. However, close contacts with persons with COVID-19, attending gathering, having visitors in the home were associated with COVID infection among children and adolescents. The evidence to date suggests that staff to student and student to student transmission are not the primary means of exposure to SARS coronavirus infection among infected children. Several studies have also concluded that students are not the primary source of exposure to SARS corona infection among adults in school settings. So schools should consider levels of community transmission as they assess the risk of transmission within the school. If community transmission is high and community vaccination level is low, the students and staff are more likely to come to school with being infectious and introduce corona infection to the school. The majority of the cases that are acquired in the community and are brought to the school result in limited spread inside school when multiple layered prevention strategies are in place. With approximately 1/4 of teachers at high risk of serious consequences of COVID-19 because of their underlying medical conditions, reasonable concern have been raised about the occupational risk of this infection for teachers and school staff. Evidence from studies primarily done before vaccine approval for those 12 years of age and older suggests that staff-to-staff transmission is more common than transmission from students to staff or students to student or staff to student. A study comprising COVID-19 hospitalization between countries with in-person learning and those without in-person learning found that the effect of in-person school reopening on COVID-19 hospitalization rate when baseline county hospitalization rates were low or moderate. Significant secondary transmission of SARS coronavirus 2 infection has occurred in school settings when prevention strategies are not implemented or are not followed. In Israel, prior to vaccine introduction, a school was closed less than 2 weeks after reopening when 2 symptomatic students attended in-person learning, leading to 153 infection among students and 25 among staff members from among 1,161 students and 151 staff members that were tested. Importantly, prevention strategies were not adhered in that school that time, and including lifting of mask requirements were there because of the heat wave, classroom crowding, and poor ventilation. Although outbreaks in school can occur, multiple studies have shown that transmission within school setting is typically lower than or at least similar to the levels of community transmission when prevention strategies are in place in a school. If COVID-19 is spreading in your community, stay safe by taking some simple precautions, such as physical distancing, wearing a mask, keeping room well ventilated, avoiding crowds, cleaning your hands, and coughing into a bent elbow or tissue. Studies of SARS coronavirus 2 transmission in schools that consistently implemented layered prevention strategies have shown that Success in limiting transmission in schools, even when testing of close contact has been incomplete. A study of 11 school districts in North Carolina with in-person learning for at least 9 weeks during the fall of 2020 reported minimal school-related transmission even while community transmission was high. These schools implemented and strictly adhered to multiple prevention strategies, including universal mask use and physical distancing. Breaches in mask use likely explain the few instances of school spread of coronavirus infection. Now, promoting vaccination. COVID-19 vaccination among all eligible students, as well as teachers, staff, and household members, is the most critical strategy to help schools safely resume full operations. A growing body of evidence suggests that people who are fully vaccinated against COVID-19 are less likely to become infected and develop symptoms and are at substantially reduced risk from severe illness and death from COVID-19 compared to the unvaccinated people. Only a small proportion of fully vaccinated people get infected, even with Delta variant. Moreover, when this infection occurs among vaccinated people, they tend to be milder than among those who are unvaccinated. However, preliminary evidence suggests that fully vaccinated people who are infected with Delta variant can be infectious and can spread the virus to others. To reduce the risk of becoming infected with the Delta variant and spreading it to others, students, teachers, and school staff should continue to use layered prevention strategies, including universal masking in the school. So, vaccination is the most important strategy. Then face mask. How to, mask was the combination of source control and prevention for the mask wearer. The most effective fabric for cloth masks are tightly woven, such as cotton and cotton blends, breathable, and in 2 or 3 fabric layers. Center for Disease Control recommends universal indoor masking by all students from age 2 and older, staff, teachers, and visitors to kindergarten to standard 12 schools, regardless of vaccination status. Before wearing mask, wash your hands before wearing mask, after touching the mask. You should touch only the bands or ties when the putting or taking of your mask. And you should wash reusable masks after each use. If the mask is disposable, discard it when it is visibly soiled or damaged. You should have 2 or more layers of washable, breathable fabric. Completely cover your nose and mouth. Fit snugly against the sides of your face and don't have gaps. Have a nose wire to prevent air from leaking out of the top of the mask. And find a mask that is made for children to help ensure proper fit, and properly wash your hands after putting the mask. And you should not use fabric that makes it hard to breathe, like vinyl cloth, etc. And never use the mask with valve that will allow leakages of virus. And do not use the N95 mask, which should be reserved for the healthcare workers. And while removing the mask, carefully untie the string behind your head or stretch the ear loops. Handle only by the ear loop or ties. Fold the outside corners together and dispose it safely. Be careful not to touch your eyes, nose, and mouth when removing, and wash hands immediately after removing. Mask use should be required on school buses and public transportation. School systems should take appropriate steps to ensure compliance with this requirement by students, staff, and others. If visitors are permitted in school, they should be required to wear masks at all times and should maintain physical distancing. Schools should encourage modeling of correct and consistent mask use by school leaders, local leaders, and other special respected in the community. Next is physical distancing. In many settings, the physical distancing has been defined as at least 6 feet. This recommendation was based on historical studies of other contagious diseases such as SARS coronavirus in the past. However, emerging international evidences suggests layering of other prevention strategies is effective at reducing the COVID spread, even with physical distance of less than 6 feet between students and in the classroom. Several studies from international studies published in 2020 reported low level of transmission with the students if they maintain 1 meter, approximately 3.28 feet between students in school. Recommendation from WHO and American Academy of Pediatrics using a distance of at least 3 weeks between students in a classroom could provide a feasible definition of physical distancing so long as the prevention strategies are maximized. But maintain 6 feet of distance in the following settings: between adults, that is teachers and staff, and between adults and students at all times in the school building where mask cannot be worn, such as when eating. During activities when increased exhalation occurs, such as singing, shouting, bands, or sports or exercise. In common areas such as school lobbies and auditoriums. And you should remove the non-essential furniture and make other changes to classroom layout to maximize distance between students. And face the desks in the same direction whenever possible. And eliminate or decrease non-essential in-person interactions among teachers and staff during meetings, lunches, and other situations that could lead to adult transmission. Next is ventilation in schools. If safe to do so, open windows and doors. Even just cracking open a window or door helps increase outdoor airflow, which helps reduce the potential concentration of virus particles in the air. If it gets too cold or hot, adjust the thermostat and do not open windows or doors if doing so poses a safety or a health risk to the children, such as falling, exposure to extreme temperature, or triggering asthma symptoms, etc. Using child-safe fans may help to improve the circulation. Consider having activities, classes, or lunches outdoors when circumstances allow. Open windows in transportation vehicles. Very important, hand washing. You should wash your hands before and after touching your eyes, nose, or mouth, touching your mask, entering and leaving a public space, touching an item or surface that may be frequently touched by other people, such as door handle, table, gas pump, shopping carts, or electronic cashier register, screen, etc. And while washing, you should follow these 5 steps. First, wet your hands, then get the soap, scrub it properly, apply it between palms, rub it on the back of your hand, then rub in between fingers, thumb, and base of your palm. And that should cover all the areas of the hand. Then that should take around 20 seconds. Then rinse your hand and dry it with a clean cloth. If soap and water is not available or not practical, you may use this hand sanitizer with minimum 60% alcohol content. You should apply it and rub it same like how you wash your hand with soap and water, and that should also take around 20 seconds, and you should allow it to dry by air. Also important to follow respiratory etiquette. While coughing and sneezing, you should cover your face and nose with tissue. If tissue is not available, use your inside of your elbow. Throw the tissue to a clean dustbin and wash your hands each time. Another preventive strategy is staying home when sick and getting tested. Staying home when sick with COVID-19 is essential to keep COVID-19 infection out of school and prevent the spread of the disease. If a school does not have a routine screening testing program, the ability to do rapid testing on site could facilitate COVID-19 diagnosis and inform the need for quarantine of school contacts and isolation. Schools should educate teachers, staff, and families about when and how their children should stay home and when they should return to school. During the COVID-19 pandemic, it is essential that parents keep children home if they are showing signs and symptoms of COVID-19 and get them tested. Getting tested for COVID-19 when symptoms are compatible with COVID-19 will help in rapid contact tracing and prevent possible spread at school, and especially if the key prevention strategies are not in use. And what to do if a student becomes sick or report a new case of COVID-19 diagnosis in school? That student should be excused from the class and by the teachers and staff, and the COVID-19 point of care team should be informed, and that team should take the student to the isolation room and ensure it is properly supervised and masked. Then the parents or guardians should be informed, arrange the transportation to their home. Parents come and pick up the students and contact the healthcare providers for evaluation and possible COVID-19 testing. After this is done, you should clean and disinfect the area that the ill students occupied. Ventilate the area. Wait as long as possible before cleaning to let the virus particles settle, at least several hours, and use personal protective equipment, including any protection needed for cleaning and disinfection products to reduce the risk of infection. And if more than one student must be placed in the same isolation room, make sure mask use is properly done and stay at least 6 feet apart while supervised. And once a test comes, the report comes, if the students are negative, students can return to the school following existing school illness management policies. If the student is positive, it should start home isolation. And the ill students can return to school and end isolation once the followings are met. That is 10 days out of the start, 10 days from the start of the first symptom, and no fever for at least 24 hours without any fever reducing medications. And all other symptoms have improved. And also this point of care team should inform, that should make a list of the close contacts of the ill students and inform staff, parents, guardians, and caregivers of close contacts of possible exposure so that they can be tested. And they work with the local health officials to assess the spread and support follow-up with the staff, parents, guardians, and caregivers so that those who had contact with the ill student. Parents, guardians, or caregivers of the close contacts are advised to keep their children home. And members of all the students, household, and staff who had the contact with the student are advised to quarantine according to the local health department requirement. This close contact means someone who was less than 6 feet away from the infected person for a cumulative period of 15 minutes or more within 24 hours. If it is less than that, that will not be considered as close contacts. But there are exemptions, like in the indoor classrooms for the school children, it could be 3 feet. If they are within 3 feet for this much period, then they are considered as close contacts. But this exception does not apply to teachers, staff, and other adults in the indoor classroom setting. Visitors. School should limit non-essential visitors, volunteers, and activities involving essential group or organizations, particularly in areas where there is moderate to high risk of COVID-19 community transmission. Schools should not limit access for direct service providers, but instead can ensure compliance with school visitor policies. Schools should continue to emphasize the importance of staying home when sick. Anyone, including visitors who have symptoms of infectious illness, such as flu or COVID-19, should stay home and seek testing and care, regardless of vaccination status. Food services. Staff should wear masks. That means the food service staff should wear masks at all times during meal preparation and service and during break, except when eating or drinking. Students should wear masks when moving through the food service line. Maximize physical distance as much as possible when moving through the food service line and while eating, especially indoors. During additional space outside of the cafeteria for mealtime seating, such as the gymnasium or outdoor seating, can help facilitate distancing. Students should not exclude from the in-person learning to keep the minimum distance requirement, including during the mealtime. Because if the school don't have enough space, just because of this rule, we should not exempt students. Given very low risk of transmission from surface and shared objects, there is no need to limit food services to single-use items or packaged meals. Clean, frequently touched surfaces that come in contact with the food should be washed, rinsed, and sanitized before and after meals. Improve ventilation in food preparation, service, and seating areas. Sports and other extracurricular activities. Team sports or other types of group extracurricular activities can increase the risk of COVID-19 transmission for participants, coaches, and spectators, as well as among other students, teachers, and staff. Close contact team support and indoor sports such as wrestling appear to represent particularly high risk of activities because participants cannot maintain distance from each other and ventilation option may be limited. Intense exercise causes participants to breathe heavily, which can cause potentially infected respiratory droplets to travel farther than they would from person upon exhaling at rest or normal circumstances. Other extracurricular activities, especially ones that occur indoor and involve shouting or singing, also increase the risk of transmission if the participant is infectious, because respiratory droplets may be generated at higher rates and potentially travel greater distance. Relocation of activities to outdoors or other well-ventilated venues, as well as vaccination of eligible students and adults who support these activities, such as coaches, volunteers, teachers, advisors, etc., will be important contributors to reducing the risk of COVID-19 for those who play sports or engage in high-risk extracurricular activities. Now, to sum it up, schools are an important part of the infrastructure of the communities. They provide safe and supportive learning environment for students that support social and emotional development, provide access to critical services, and improve life outcomes. They also employ people and enable parents and caregivers to work. Though COVID-19 outbreaks have occurred in school settings, multiple studies have shown that transmission rate within school settings when multiple prevention strategies are in place are typically lower than or similar to community transmission levels. Consistent with recommendations from WHO and American Academy of Pediatrics, using a distance of at least 3 feet between students in classrooms could provide a feasible definition of physical distancing so long as other prevention strategies are maximized. We should ensure proper wearing of the mask, physical distancing, hand sanitization, disinfecting the frequently touched areas, and properly ventilating the school, and stay home whenever you have symptoms, and get tested, those who have symptoms, and get vaccinated appropriately. And we should avoid gathering, close contacts, and handshaking, and touching the potentially contaminated areas. And we should avoid touching our eyes, nose, and mouth with unwashed hands. Also avoid sharing food, not because corona transmits through food. It is to avoid the cross contamination. I would like to end this presentation with this take-home message. Safe in-person schooling can be well accomplished without increasing the risk of transmission of COVID-19 in the community when multiple prevention strategies are in place. Thank you so much for the patient hearing.